Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. And today we're excited to dive into a topic about 340B. This is an education for me, and I love these type of interviews because I learn a lot, and I think our audience learns a lot as well. So we're excited to welcome Lisa Scholz. She's the head of industry relations at Sentry Data Systems. Welcome, Lisa.
Well, thank you so much, John. I'm really enthusiastic to be able to share with you today some perspectives on the latest from HRSA, from the Health Resources Services Administration. But really, from my vantage point, having been 20 years in this space with 340B experiences, from actually being in the shoes of hospitals to working for HRSA previously, to standing up and representing the interest of covered entities while I worked at an association in Washington, D.C. representing covered entities, to now being in a place here at Sentry Data Systems where I'm able to really leverage the relationships that I've built over time to support 340B entities in this world that is moved from manual spreadsheets to utilizing technology to really bridge some of the complicated policies to what a hospital or a clinic's day-to-day operations look like. So, here at Sentry, we help covered entities like hospitals and clinics manage their claims day-to-day, from whether that's Medicare Part B to Medicaid, and we also help them determine patient eligibility for 340B. So Sentry is really focused on reducing the total cost of care at the end of the day, helping manage compliance, but ultimately is really to help hospitals and the covered entities produce better quality at the end of the day and have savings as a result of that.
Let's dive into, what's been the challenge of 340B eligibility when it comes to new locations?
Yeah, so it's really interesting. So obviously you mentioned COVID and the challenges that health systems in general have had around maneuvering new policies, new technology like telemedicine. Well, in June, Apexis, which is HRSA's government contractor, updated some clarification regarding patient eligibility for what we would call unregistered child sites. So the 340B program requires covered entities to have their sites, quote unquote, registered online and available. But the COVID has really created some interesting scenarios for hospitals because the registration period is usually a quarterly basis. So COVID obviously isn't looking at timelines and deadlines. It is, you're moving and you're making changes day to day based on patient needs, patient care. So a lot of hospitals had to revert really quickly. They added sites, they added new places where patients could get access. But then there came this conflict of policy, and policy oftentimes doesn't meet the day-to-day of what you're dealing with. So HRSA put out clarification, which basically said that while you may not have your hospital site registered online, you may very well have a patient who is truly eligible because they have been seen at your parent hospital site. Now, again, it doesn't take away the fact that the hospital still has to have their sites listed on the Medicare cost report, and that they really should still register them, but it gave them some flexibilities that really were unclear or weren't quite known by a covered entity. So again, it was very positive from the standpoint of allowing those hospitals that have these sites coming up to be able to get access to those drugs for those particular patients.
What does the new HRSA FAQ say about 340B eligibility for these off-site outpatient facilities, and how could it help solve some of the challenges that many organizations have faced?
What it means really at the end of the day, when we look at what the long-standing guidance has been from HRSA, and that's guidance that's been around since 1994, is you still must have that hospital's new location registered. But I tell you that the one thing that it does, if you think about the Medicare cost report and the time that it takes to file a cost report, I'll give you an example. So in January of this year, let's say we have a new site that's added. For whatever reasons, there is a new practice site, whether it's treating cancer patients, whether it's treating heart conditions. That site today, when you think of how it has to be registered, would not technically be available to be on the cost report, because the cost report filing period is from January to December in some cases. For other hospitals, it depends on their fiscal year. But yeah, in this case, let's take the hospital that has a January to December filing time. Well, in January, they would not have had that particular site on their cost report. What would normally happen is that hospital would not be able to provide drugs to the patients that were being seen in that site until that particular site became eligible on the cost report, which means the following year, in roughly May of 2021, the hospital would finally have what we call a final cost report filed. That would then trigger them to be able to apply through HRSA's online reporting system in July. That's the next opening period that it would be. So now you're looking at July 1st through the 15th being able to enroll, and you don't actually get to participate until the following quarter, which in this case it would be October 1st. So you're looking at, roughly in this scenario, almost a 22-month delay before you could actually have those patients eligible. What the new guidance does is it says, well, that patient may very well be a part of your health system already. And as long as you have the appropriate documentation and you have eligible visits within your hospital system, that those particular patients may very well have eligibility. So again, while they're not quite listed on the cost report, and HRSA is not saying don't do that, they still are telling you you need to register, but it's giving a little bit more of a nuance to how you look at a patient, and that just because that cost report isn't necessarily filed and complete, there may very well be a case for that patient to still have eligibility. So it's a very good win for hospitals that are responsible for the care that those patients are receiving, and oftentimes those patients are relying on the health system to support them for their medication needs.
Sure, I mean, 22 months is, it's hard to process, having to wait that long. But
it's a long time.
It seems like there's a little caveat though, because you said, and I think in the rule, I think it's called patient definition, right? So as that's written into the law, how does that play here, right? I mean, what is considered a patient that's existing? I think you said in the health system. What does that mean?
Exactly, and patient definition is kind of the center of 340B for all covered entity types, whether you're a hospital or whether you're a community health center or you're a Ryan White HIV/AIDS clinic. Patient definition it's a three-pronged approach. So that is, an individual is a patient of a covered entity, such that the covered entity has established a relationship with that individual, and that's what's key. And that entity is responsible for maintaining records of that individual's care. So that's the first test. So is that patient, do you have a relationship with them? And then, so when you look at, you've bought a clinic, it's now part of your health system, is that responsibility with the hospital? So there's point one. Point two is the individual that's receiving that healthcare service has to be from a healthcare professional who is either employed by the covered entity or provides healthcare under a contractual or other arrangement. And that other arrangement oftentimes is called a referral. But at the end of the day, that responsibility for care provided still remains with the covered entity. And then the third approach, and this does not include hospitals, but it's for grantees, is that the patient actually has to have services that are part of that grantee. So in other words, when you receive a 330 grant, your grant has to actually cover the scope of care for the providers that your patients are seeing. And I'll give you an example. So if I was a community health center and my scope of grant did not include dental services, as an example, but I eventually do get a dentist to come in once a week, because that dentist isn't written into my scope, I would not be able to fill prescriptions for that dentist's care for patients. And that's just one scenario. But as long as it eventually does get written in as part of the scope of the services, then you're covered.
Right. So how does this really impact, and what does it really mean in terms of potential 340B savings for an organization? And maybe we can include in this, how does it affect, say, smaller clinics or those treating the indigent patients?
Yeah, so really what this does for, we'll talk about, if you are seeing patients who are indigent in some of these clinics, what it's going to allow you to do is to provide discounted medications, free medications, much, at a cost that can help, again, help that patient be able to manage. So if we had the scenario of not being eligible, it doesn't mean that the hospital isn't going to help them. The hospital had to pay more money to get those drugs, so they did not have the savings that the 340B program provides to them. So in those scenarios, when we talk about indigent care in those facilities, it's going to allow the covered entity to stretch scarce resources, which is, instead of me being able to help 2 patients, I'll be able to help 4 patients, again, because my costs are reduced. So at the end of the day, that is really what the 340B program is enabling hospitals to do, is be able to do more, with less money at the end of the day. And being able to access 340B is critical to that.
Yeah, and it feels like these patients that need these type of discounted drugs is only going to grow, and maybe I'm biased because I come from Vegas with a 15% unemployment right now, and it was at 30. So I think, we're going to face more of it. It seems like.
Yeah, John, I think you're right. So one of the things that we're seeing in the trend in the right now because of COVID is we're seeing job loss. And with job loss comes loss of insurance. With loss of insurance, you have patients who are looking at, how do I get care? Where do I go for care that I can afford? And oftentimes it ends up being the safety net, and that safety net infrastructure typically is community health center based care, it's hospital based care with specialists, and that is where those particular patients are often going to lean. So we're going to see they're going to need care, and if they don't get that care, they wait, they're going to end up in the emergency rooms, they're going to end up in urgent care clinics, again, within that safety net threshold. So the other effect, though, we're also going to see is when people do lose jobs and lose insurance, there's also going to be an increased need for Medicaid. And that's going to be another highly reliant government program that many patients may qualify for because, again, job loss. And the safety net is one way that Medicaid is able to stretch scarce resources, because when in Medicaid, the prices for 340B are actually passed along to the state directly. So again, I see a great need for that. So I definitely hear where you're coming from when you talk about Vegas, as well as many other places all across the country experiencing that.
Yeah, definitely. So what would you suggest to covered entity hospitals that they need to know, or what should they do next?
I think the first thing that an entity really does need to do is sit down internally and have a conversation with their finance team. That's where it starts. The finance team is responsible for filing the Medicare cost report, and really have that conversation with that group to make sure that you have all the proper documentation and that you're able to connect the dots for establishing the patient definition, responsibility of care, and then having the conversation with that group about adding those particular clinics to the Medicare cost report so that they do eventually get added, but that you've done all your homework. Because if you can prove that that child site is part of the entity, as we've talked about, those patients may very well be covered under 340B. So again, that's going to help really help your patients gain access. And then as soon as that location does appear on the Medicare cost report, obviously registering it on the Office of Pharmacy Affairs information system. So those are first steps. And second would be just continuing to stay educated and understanding your patient population and the clinics that you're seeing so that you can continuously evaluate clinics like that, because it's probably not the first time that will happen. Hospitals oftentimes are looking at different clinics and looking at maneuvering them, and that affects the cost report.
As a 340B management and compliance software partner, how has your organization been able to help clients with changes like this and others?
I think the first thing is providing the education and the knowledge and the awareness that when HRSA does come out with either updated guidance, new guidance, that we are making sure that it's in the hands of our customers, and that is key. First starts with knowledge and awareness. In particular with this scenario, the step for a company like Sentry is having the conversation with the customer and kind of showing them the steps they need to take internally, because as a provider, obviously we can assist them make sure that those clinics are eligible and that their data feeds are pulling through appropriately. But our job really is to just make sure they understand what they need to do internally before we as a technology company even turn anything on for them, because the data lives and maintains with the covered entity, and they are the ones at the end of the day that are responsible for making sure that they have a compliant program. Our job is to make sure that the levers and the buttons that they pick and choose will do exactly what it is they need to do to maintain that eligibility and management.
I mean, I think it's so powerful. I've seen this over and over again in the healthcare IT world, that finding a good partner like, Sentry Data Systems that understands all the intricacies, that's staying on top of it, that's had people that worked at HRSA, et cetera, is just so valuable. So thanks so much for sharing this insight on the changes that are happening and that better understanding this regulations. So, if people want to watch this, we'll be posting it on healthcareittoday.com. We can find all the great healthcare IT content. Thanks, Lisa.
Thanks, John. Take care.